AML Hub podcasts, brought to you by Scientific Education Support.
Hello and welcome to the AML Hub podcast. Today we'll be hearing from Charles Craddock from Queen Elizabeth Hospital in Birmingham, UK.
Hello, I'm Charlie Craddock. So I have been asked to make some comments about the role of pre-transplant MRD in determining treatment options in AML, and by implication, transplant options. And this, I think, is an increasingly important topic and an area of active, sometimes heated debate. It reflects, I think, the fact that allogeneic transplant is increasingly recognized as a pivotal curative strategy in an increasing number of adults with AML. And that's partly because we have increasingly refined risk stratification using both post-chemotherapy MRD after a couple of courses of induction chemotherapy, and also genomic data emerging from NGS that allow us to more accurately risk stratify adults with AML to predict their outcome if treated with intensive chemotherapy alone. I don't have time to go through the really elegant piece of work by the ELN AML transplant group led by Jan Cornelissen, which has identified that providing a suitable donor is available and the patient is fit, the patients with a relapse risk that's predicted of more than 45 or 50% if treated with intensive chemotherapy alone are very likely to benefit in terms of prolonged survival from an allograft. But of course, once you have a threshold in that region, that means that really many patients over the age of 50 are almost allomandatory. And we're also recognizing that there's a significant number of younger patients who will benefit from a transplant. So that's one reason for an increased role of allogeneic transplant. The second is, of course, that there's increased availability of unrelated haplo and cord blood transplant options, so that it's an error to say that everybody has a transplant option, but a very sizable majority of fit adult patients with AML with a predicted risk of relapse in the region I've identified can, if the physician recommends and the patient wishes, proceed to transplant. So the data that has accrued demonstrating a benefit of transplant has primarily been identified in adults in morphological first remission. There is clearly a role for allogeneic transplant in patients who relapse and achieve a second remission, and there's good long-term survival in that population. And also this emerging data that a proportion of patients with primary refractory AML, defined as failure to achieve a morphological CR after 2 courses of induction, can have about a 20 to 25% long-term survival. But let's just dwell on this bulk of patients who are transplanted in morphological CR. And the retrospective data there has shown really quite strikingly that patients with detectable MRD, as defined by either flow technologies or molecular strategies, or more recently NGS, in retrospective analysis have a higher risk of disease relapse post-transplant. And actually in some of the, particularly the flow-based studies, that's a very much higher risk of disease relapse compared with patients who are MRD negative. So that's led to the notion that in these patients, maybe the transplant outcome is so poor that they should receive a further course of chemotherapy to try and optimize their MRD status. And I think that that is a conclusion that I profoundly disagree with. And the reason for that is primarily twofold. The first is that I emphasize the fact that most of the analyses that are informing this decision are retrospective, and we all know how flawed retrospective registry clinical trial data can be in terms of potential selection bias. But of course, that's equally true when you are putting together retrospective translational data sets. And we have found in the only prospective study looking at flow-determined pre-transplant MRD in the Figaro trial recently published in JCO from the NCRI AML Working Party, that although indeed there is an increased risk of disease relapse post-transplant in patients who are flow MRD positive pre-transplant, and this is work led by Sylvie Freeman, actually patients, as long as they're in morphological CR who are flow-based MRD positive, can actually achieve a really encouraging long-term disease-free survival. So the argument, therefore, that we should deny patients a transplant if they're flow MRD positive is simply not borne out by our data. Certainly, the relapse risk is higher, and strategies to reduce that, simple strategies such as optimizing cyclosporine taper, thinking about the use of DLI, and as I'll touch on in a minute, thinking about the use of a myeloablative regimen where possible, are highly relevant in this setting. They should not preclude patients from receiving a transplant that can deliver long-term survivals in the region of 30 or 40%. And the second major reason why I don't think that such patients should be denied a transplant is because there's no data that compellingly demonstrates that patients who receive an additional form of chemotherapy will have improved transplant outcome. And again, this is largely because the data sets that we do have are retrospective and largely unsatisfactory. And there isn't any randomized data that shows that in patients who are MRD positive, the utilization of an additional form of chemotherapy, the course of chemotherapy pre-transplant, will improve outcome. In other words, pre-transplant MRD is prognostic but not predictive. So that's the reason why I would be suggesting that as long as people are in remission, they should go to transplant regardless of MRD status. Now, that doesn't necessarily mean that it shouldn't inform how we transplant patients. And I think one of the most important considerations there would be whether one would wish to employ a myeloablative regimen rather than a RIC regimen. Now, certainly in younger patients, the use of a myeloablative regimen in MRD positive patients is really the optimal transplant approach. I'm thinking of patients under the age of 55. And that's based largely on Chris Hourigan's data from the USCTN study looking at MAC versus RIC, in which he demonstrated that pre-transplant NGS positive MRD patients did better if they had a MAC allograft rather than a RIC allograft. I mean, it's important data. There are limitations with that analysis. The relapse risk in the RIC arm using FP2 was much higher than has been observed in other prospective studies using FP2. And the relapse risk in the myeloablative arm in the USCTN study is much lower than was reported by Rambaldi in his pivotal Lancet Oncology study. So I think there are some caveats about the study, but it would seem sensible in a fit adult under the age of 55, where a MAC can be delivered safely, to choose that as the option. The challenge, of course, is in patients who have some comorbidities or older patients where it's likely that a MAC regimen may not be so well tolerated, about how you improve transplant outcome. And I think it's there that early cyclosporine tapers, possibly the use of preemptive DLI, and entering into a trial examining the benefit of post-transplant maintenance is really important. Finally, we clearly need to generate prospective data in this setting, and the UK Impact Transplant Consortium is accruing rapidly to 2 pivotal studies. One is a study called COSI, and COSI has 2 main randomizations. The first is in allomandatory patients with AML and CR1, to ask if there has to be a delay requirement, therefore, for bridging chemotherapy before coming to transplant. And about 70% of patients, that's the case, to randomize patients to intermediate dose RST, 10 grams total, versus CPX. So that's, I think, a very interesting randomization, asking the impact of a different form of chemotherapy on both MRD status immediately prior to transplant and transplant outcome. And it's underpinned that rationale by the provocative data from the Jeffrey Lancet CPX versus DA licensing study in JCO from about 4 or 5 years ago. Not only did that study show improved outcomes in patients who were treated with CPX in terms of overall survival, but also when patients were censored at transplant, the patients who went on to transplant who'd received CPX rather than DA had a much better post-transplant outcome. Now, whether that was because of a reduction in relapse or actually reduction in non-relapse mortality is still unclear. But the idea that CPX might be a preferred agent to get to transplant, I think, is there and is being tested in randomization 1. And then in COSI, the other important randomizations are, again, looking at the conditioning regimen, and we're looking in a randomized manner at the myeloablative TBF regimen versus the myeloablative FB4 regimen in patients under 55, and in patients over 55, looking at a reduced intensity TBF versus a standard FB2 regimen. And the other important impact study, I think, in this setting, which is recruiting rapidly as well, is AMADEUS, which is a randomized study looking at CC486 maintenance. And it may well be that such maintenance strategies are important in the MRD positive older patients coming to transplant. So in conclusion, I think this is a really important question. Certainly takes up a fair bit of time at our MDT, and I know other MDTs across the country. My conclusion is based largely on the small amount of prospective data we have available, but I think that compellingly confirms that taking patients in CR to transplant is the right thing, and that we shouldn't be deferring transplant while additional chemotherapy is administered. All sorts of bad things can happen during that time, which potentially stop patients receiving a curative therapy. And finally, I think it's a plea, and I think there's abundant evidence that as a transplant community, we need to be working together to generate the prospective randomized data that would be considered absolutely essential if we were developing new therapies in myeloma, AML, lymphoma, and which has been until recently so singularly lacking in AML. And such prospective studies must address in a formal randomized design interventions with the potential to improve transplant outcome. One of these is whether intervention in MRD positive patients is a benefit, and they also must have integrated MRD, sequential MRD and genomics built in. And it's really only because of the incredible hard work and goodwill of so many transplant physicians and research nurses across the UK at impact centres that we're able to deliver the COSI trial so quickly, which we hope will close out in 2022. So thank you very much for your attention.
Thank you for listening to the AML Hub podcast. We would also like to thank our supporters, Genentech, Roche, AbbVie, Amgen, Novartis, Bristol Myers Squibb, Janssen Oncology, and Jazz Pharmaceuticals.
AML Hub podcasts, brought to you by Scientific Education Support.